Okay. All right, everyone. I think we'll get started. We've got a lot to cover this afternoon as well. For those of you who weren't here this morning, I'm Phil Bedard, one of the medical oncologists, and I'll be chairing the session this afternoon. There's just a few announcements that I'd like to make. First and foremost, this meeting has been great, and it wouldn't be possible without the support of our generous sponsors, including the platinum level sponsor, the Princess Margaret Cancer Foundation, a pearl level sponsor, Roche, our silver level sponsors, AstraZeneca, Pfizer, EMD Serono, and Merck, and Bristol Myers Squibb. So that's the first thing. Second thing, the whole session is being taped. Some of you may have seen the video camera at the back. All of the sessions will be available on the website after the meeting. So if you don't feel like you have to jot down every note or take pictures of the slides, it'll all be available on the web. And then the third thing is we'd really encourage you, this is the first year we've done this meeting, to complete your evaluation, which is in the package. It's really important for us to have feedback from the attendees of the meeting about how we can improve this in the future. And your CME certificates are linked to completion of the course evaluation, or the symposium evaluation. Okay. Anything else I missed, Lillian? The TIP website, yeah, the TIP website. Sorry, the TIP website. Okay, so to get the afternoon started, it's actually Ming's slides. Our first speaker is Dr. Ming Tsao, who's a professor of laboratory medicine and pathology here at the University of Toronto and at the UHN. I don't think he needs any introduction to this audience. Ming is a leading translational pathologist in the area of lung cancer. He's led many projects that have sort of led to the development of standardized biomarkers in lung cancers and in other diseases. And he has a very rich research program that looks at various different patient-derived xenografts and other models to study molecular pathogenesis. So Ming's talk, which I think is on the top of all of our mind as clinicians, is the status of PD-L1 testing. Where is it at and what's next? Ming.
Okay, thanks, Phil, for the introduction. Also for the organizing committee for inviting me to give this talk. So I hope that at the end of the talk that there will be some clarity about the PD-L1 testing at the clinical level. Anyway, so this is my conflict of interest disclosures. And so I will be covering PD-L1 immunohistochemistry assays, and PD-L1 as a predictive marker in the immuno-oncology trials, and comparability of PD-L1 assays, and also some challenges and alternative markers. So I think that, I think early on you have a lot of this, the biology of the immuno-oncology. So I'm just going to focus that the target of the checkpoint inhibitors are the negative regulator of T-cell activations, PD-1, PD-L1, and also CTL4. But I think what we're going to focus is on the PD-1 pathway, and there are 5 drugs that have been developed, and so it's on the right-hand side. And I'm not going to talk about the CTL4 pathway blockade. So now the biomarker, the PD-L1 testing right now is relevant only in lung cancer, although this has been evaluated in all type of cancer, solid tumors, and also, I guess, the other type of tumors. And it's important to remember that actually there are two agents which the targets are the PD-1. The other 3 agents are the targets are PD-L1. Okay, there are 3 2 of them has been approved for use in lung cancer, and 1 of them is pending. And so that the assays that has been developed to assess the PD-L1 expression has been developed independently by each companies, and this is in part to be compliant with the FDA's requirement for the development of companion diagnostic. And so you can see that there are, in fact, the PD-L1 antibodies that are developed with each of the drugs are different, right? So in fact, you can look at the epitopes. 3 of them are extracellular, 2 of them are intracellular. Not only that, the companies that actually, the diagnostic companies that develop the assays are different. There are two of them, DECO and Ventana. And they are sort of developed independently. And the system they developed is by the diagnostic company. So now you can start imagining the complexity of this assay. So what is important is to remember, in the clinical diagnostic sort of levels, I think the clinical diagnostic assay systems, you have to take into account not only the antibody that is staining and how the staining is conducted, and also how the whole diagnostic algorithm, the cutoffs, and what you use to select patient for treatment. So it's the whole thing has to be considered together, not just the antibody and also the staining itself. So I think the first indication that in fact the PD-L1 status or expression actually correlate with the response of to the immunotherapy. The checkpoint inhibitor is the Nivolumab. You can see that in fact in these phase 1 trials that in fact the response rate is much higher in those which have a high expression of PD-L1 tumors. And this is the first, Nivolumab is the first PD-1 antibody, and this is the first the two phase 3 trials are the Checkmate 017, Checkmate 057. One is actually in the squamous cell carcinoma, lung squamous cell carcinoma. The other one is the non-squamous carcinoma. And this is the second-line patient who actually have been treated previously with chemotherapy, and then now they're comparing the second line, whether they get the Nivolumab or the second line chemotherapy docetaxel. And you can see that the primary endpoint are the overall survival, and there are additional endpoints. So now we focus on the squamous cell carcinoma. In the squamous cell carcinoma, you can see here that in fact the Nivolumab has, this is overall survival, show a survival advantage compared to the second-line chemotherapy, which is docetaxel. And what is important, in fact, in the immunotherapy is that this is overall survival. You can see at the end of the almost like the 2 years, in fact, the curve is flattening out. This is survival, right? So, and this, I think, is something which is really excite the lung oncologists, because you don't see that previously. I think that these are patients who are advanced patients, and after first chemotherapy, and you see the docetaxel is going down to 0 at the end. So the PD-L1 assay for this Nivolumab is 28.8, and the antibody is 28.8. The assay actually evaluates the staining on the tumor cells only. And you will see the staining on the membrane of the tumor cell, whether it's partial or complete. And then the way it was scored is that they evaluate how many % of the tumor cell is staining positive, showing this membranous staining. Okay, you can see that 3+, 2+, 1+, etc. This is in the development. So you can see here that in fact, at the end, the assay actually does not consider what is the intensity of the staining, because it turns out that intensity does not really matter. It's more the percentage of the tumor cell showing staining is more important. But in the case of the squamous cell carcinoma, you can see the different cutoffs, 1%, 5%, 10%. There is really no difference in terms of the survival advantage or the hazard ratio, right? So you can see that the hazard ratio, if it's to the less than 1, it's as Nivolumab is better than chemotherapy. It's more than 1%, is chemotherapy better than Nivolumab. And you can see they're all below 1, and regardless of the percentage. So this is why I think in the squamous cell carcinoma, lung squamous cell carcinoma, you don't need a biomarker. You don't need a PD-L1 testing to basically for treatment with the Nivolumab. Now, in the non-squamous non-small cell lung cancer, again here, you see that there is a overall survival advantage for Nivolumab compared to the docetaxel. But now it's a little bit different. And you can see that the different percentage. This is the starting from the left-hand side is less than 1%, and then this is 5% and 10%. And you can see the separation between the nivolumab and the chemotherapy actually enlarges, so it's getting bigger and bigger when you get to the 10%. Although in the less than that cutoff, in fact, there is no difference in the chemotherapy and the nivolumab. So at the end, that in the non-squamous, actually the drug was also approved as for all comers. We do not need the markers. The reason is because the nivolumab actually is comparable to docetaxel. It's not worse than docetaxel. So the PD-L1 28/8 PharmaDX assay has been approved by FDA as a complementary diagnostic. It is useful. It is said that for nivolumab treatment, it is useful, potentially useful to the clinician, for useful information, but it's really not necessary for using it to select patients for treatment. This is what's the new term that they come up with, the complementary diagnostic. Now, we come to the second PD-1, anti-PD-1 drug, the Pembrolizumab. This is the Merck Pembrolizumab. So here in the development, the phase 3 trial is the KEYNOTE-001. This is again also the second line trial. And here actually, Merck actually did quite a bit of more attention to the development of the biomarker, the assay. They actually have 1,143 patients screened, and they were looking for patients who are more than 50%. So there's 495 treated, and then they, in that first part, 182 group, they actually looking for this, what is the cutoff for those who benefit most from the treatment, from the pembrolizumab compared to the chemotherapy. And then they did a second group, which is called the validation group. They tried to validate the assay in the second group, the validation group. And here they show that, in fact, that the response rate increases with increasing expression of the PD-L1. And so the percentage PS means the TPS, basically a tumor cell, percent tumor cell staining. As you see that with increasing percent tumor cell staining, that in fact the response rate actually increases in the yellow, the overall response rate in the treated patients. So in fact, at the end, they found that in the KEYNOTE-1 that with the 50% cutoff, that the survival, this is overall survival again, showing significance of survival advantage compared to those which are TPS 1 to 49% or TPS less than 1%. So now, for this, in fact, that for the pembrolizumab, the FDA approved a companion diagnostic at 50% cutoff. And this is companion diagnosis. That means it's required for selecting patients to get treatment. So in the KEYNOTE-001, of course, it is all patients get treated by pembrolizumab. There is a subsequent trials after that. Is a KEYNOTE-10, which is basically comparing the pembro and the docetaxel, and again that shows that it was positive, but in fact the survival advantage could be also seen at 1%. The cutoff now in the U.S., the FDA just approved. The cutoff has been dropped to 1%. In Canada, it's still at 50% cutoff. So more recently, there was at ESMO, the KEYNOTE-024. This is the first line now, patients who are advanced non-small cell lung cancer, patient who has never been treated with chemo. Now they're accrued to trials, and this now the key eligibility criteria is 50% cutoff, and they randomized 1-to-1 with pembrolizumab and chemotherapy, platinum doublet chemotherapy. And this shows, in fact, that those patients who get the top one is progression-free survival, the bottom one is overall survival. Again, so that with the pembrolizumab has significant survival advantage compared to the chemotherapy, first-line chemotherapy. And so now I think that, I think in the States, at least it has been approved for the first-line treatment of non-small cell lung cancer patients who has PD-L1 more than 50% expression. Now, this is the Roche drug, Atezolizumab, and the trials is the first phase 2 trial is the popular trial. And you can see here that, in fact, the Atezolizumab also show survival advantage compared to docetaxel chemotherapy. And now the assay for the Atezolizumab was developed by the Ventana, the SP142. The SP142 assay is a little bit different because, in fact, they're scoring not only the tumor cell, but also the immune cell, the expression on the immune cells. And they come up with this very complicated, a bit complicated a scoring system where not only they score the tumor cell expression, TC 0, 1, 2, 3, so 1%, 5%, 10, 50% cutoff, and then the immune cell IC is scored separately at 1%, 5%, and 10% cutoff. And then there's a combined TC0, IC0, etc. And what is important is to look at the top, the Venn diagram. In fact, you could see that at the top there are TC3, IC3, where they're non-overlap. In fact, there are patients whose tumor actually only staining tumor cell or only staining the immune cells. And that's about 16% of the patient. There is a little overlap. So in this sort of assay, you combine both looking at the tumor cell and the immune cell. It is more complicated from the pathologist's point of view to score both the immune cell and the tumor cell. I'll explain later on why. So in the popular trial, this is, again, the phase 2 trial, you can see that the difference of using the different cutoff, that in fact there is a survival advantage when there is some staining in both either or immune cell and tumor cells. Whereas the TC0, IC0, the right bottom corner, there is no survival advantage, right? And now the phase 3 trial of Atezolizumab is the OAK trial. And this has been reported at ESMO. Again, the overall survival, you can see that there is a survival advantage for the Atezolizumab compared to the chemotherapy. And this is second line. And you can see here that if you have IC, TC more than 50% or IC more than 10%, this is the top which is 16% of the patient, you can see the survival advantage is much greater than if you have less than 1%. So basically, this is the TC0, IC0 on the right-hand side there, right-hand corner. Okay. So this also indicates that the expression of the PD-L1 does correlate with the response rate. So now we have there are two other drugs that are Nivolumab by MedImmune or AstraZeneca, and then the Nivolumab, which is being developed by Merck Serono and Pfizer. And those are still, the trials has not been, the phase 3 trial has not been reported yet. So although they are testing all the different cutoffs, but the patient selection we do not know yet for all those trials. Okay, and so now this is a complication for pathology pathologists. Now we have 5 biomarkers. How are we going to implement this clinically? So one of the questions is that how comparable are these assays to each other? Remember, they're developed independent of each other, right? So, and at the comparability is also, there are 2 levels. One is at the staining level, characteristic, it is analytical performance of the assays. Secondly, can you interchange the cutoff that is associated with the drugs that is selected by the trials? Can you interchange from one assay and then with the therapy, the drug that you're going to prescribe to the patients? Those are the questions that is asked in this called Blueprint Project. The Blueprint Project is an unprecedented because we get 5 companies, 4 pharma companies, and 2 diagnostic companies to work together, and then they provide the technical expertise. The academic group, which is the International Association for the Study of Lung Cancer, provide the pathology expertise and neutral observer, and also there is sort of a stakeholder interest by the FDA and EMA. So this was done. So what the study used a set of 39 non-small cell lung cancer paraffin blocks that are acquired by the companies. They did the staining, so the DECO stained the 2 assays they developed. Ventana stained the other 2 assays that they developed. The Ventana pathologists, 2 of them, both of them are experts in the 2 assays, and then 1 DECO pathologist who are expert in the 2 of the DECO assays. And they would score the tumor cells, the immune cells, the percentage of the tumor cells on all the slides, all the 4 assays. And then also they would provide scoring based on the cutoff. For example, at 1%, what would be positive, what would be negative, etc. So what was the result of this? This is actually presented. This was presented at the AACR in April this year, and the manuscript has just been accepted. It's going to be published in the Journal of Thoracic Oncology, and the results shows that in fact that these are the 4 assays, and the left-hand side is the tumor cell staining. Each one of those is the average of the score by the 3 pathologists, and you can see that in fact the 3 assays, the 22C3, 28A, and the SP263 are very similar. Okay, there are variations, but they're very similar in terms of their characteristic. Whereas the SP142, which is the Atezolizumab, associated with, paired with Atezolizumab, is off. It is staining less the tumor cells. Whereas in the immune cells, they all stain the immune cells. In fact, but there is a lot more variation in the scores of the scores that was generated. And here is just an example of the staining of the different assays or the same set of the same tumor sections. And you can see there is some variability. You can see the SP142 has weaker staining of the tumor cells. Okay, so the conclusion from the analytical comparison is that there are 3 assays: 22C3, 28A, SP263. Just to repeat, 22C3 for Pembrolizumab, 28A is for Nivolumab, SP263 is Durvalumab, demonstrate similar analytical performance with respect to percentage of tumor cell positive and dynamic range, whereas the SP142 consistently labeled fewer tumor cells. Whereas the immune cell staining, all assays label the immune cells, but there is less precision in analytical performance than with the tumor cell labeling. And in terms of the observer variability, the scores, there is generally higher agreement between the observers when assessing the tumor cells than when assessing the immune cell. So assessing the immune cell is quite a challenge, in fact, for the pathologists to do. So then the next question is that, so if you take the assay, remember I said the assay is the combination, also the staining, the assay, the staining and also the cutoff, okay? And then can you take that assay, can you, from associated one drug, can you apply it to the other drugs or not? So that's the question. And here is the result. In fact, that using the different cutoff, for example, SP142, what they use, the TC1, IC1 as a cutoff, 22C3 here is 1% cutoff, not the 50%. 28.8 is 1%, and the SP263 is 25%. You can see that the cases that are positive, which are the gray, are not similar, not identical among the assays, right? And then this is, I think, is expected, basically, that because they would stain, because of the cutoff, they would stain different tumors would be staining positive or negative depending on the cutoff. So the point here is that there is a potential for different diagnostic results according to the key clinical cutoffs if the assay and the algorithm are mismatched or mixed up, right? So cutoffs should always be paired with the drugs. You should not switch them around, okay? Because the cutoff are developed during the trials and identified during the trials. So one of the biggest challenges with PD-L1 as a biomarker, in fact, is that the expression heterogeneity. PD-L1 expression is not like a mutation. It's not like EGFR or ALK, where all the tumor cells will have a mutation, okay? So this expression heterogeneity is quite real, and because I think this is a dynamics of marker. And you can see this one section here, a resection tumor. If your biopsy is from the top side, you will be positive. Your biopsy is from the bottom side, and then it will be negative. And this is one of the issues. And in fact, in the scoring of the PD-L1, most of the samples are biopsies, small biopsies, needle biopsies. And really, all you need is that, according to guidelines, is a 100 tumor cell. And I circle that what 100 tumor cell is about, right? So it's really not that many tumor cells. The problem is that, if your 100 tumor cell is negative, could you be sure the rest of the tumor is negative also? And so also the other thing is that, would the expression of PD-L1 in the primary and metastatic tumor is the same or not? At this time, I think the data suggests that, in fact, at least at the clinical diagnostic, you can use both primary and metastatic tumor because they give the same result in terms of in trials, in terms of the response to the drug. And also the archival biopsy, which was the patient has never seen the treatment before, and also patient who has seen treatment of chemotherapy and post-treatment, basically re-biopsy before treatment. They are all acceptable at this time. But there is one paper come out from one study from France, Nice, and showing that, in fact, in patient whose tumor, there is a resection and also at the pair core biopsy. And this group used the TC0IC, both scoring the tumor cell and the immune cell. You can see that there is quite a discrepancy. The TC0IC0, there is overrepresentation in the biopsy specimen compared to the surgical specimen. This is the surgical specimen, the whole tumor. And what it means is that, assessing biopsy, potentially there would be false negative, right? And I think this could be confounding in terms of the result of the trials, that some of the patients who actually are negative could be responding or benefiting from the drugs. With the degree of that false negative, we do not know at this time, all right? So this is I'm just saying that this is one of the confounding factor in terms of the using of the PD-L1 as a bioassay. So now, are there other biomarkers that could be used for immunotherapy? And probably it's discussed before that lung cancer is a highly mutated tumors, and both adeno and squamous cell carcinoma, because a lot of patients are smokers. And in fact, this study come out of the Memorial Sloan Kettering suggests that the mutation rate or the mutation burden, the amount, burden of the mutation in the tumor could be correlated with response to the checkpoint inhibitor therapy. Although I think at this time, as far as I know, there is only one study, at least in lung cancer, that showed this, and the number is very small. In fact, there are very few patients who are involved in this. But we know that in the colorectal cancer who has a mismatch repair deficiency, and these are patients who actually are prone to have high mutations, and in fact that the anti-PD-L1 actually is a so anti-PD-1 therapy is very effective. Again, suggesting that indirectly that in fact mutation burden is correlated with response. And in the bladder cancer, it's a similar thing. So in the Atezolizumab is effective in the bladder cancer, metastatic urothelial carcinoma. And the study shows that in fact, that if you look at just the bottom panels, that the tumors are this is from the TCGA data, that those who have basically different, so they are clustered based on TCGA. The urothelial cancer can be, there are 4 different tumor types, molecularly defined, but in fact, those which has high mutations has high PD-L1 expression. So the two are correlated. And of course, the immune environment is very complex. There are many others checkpoint molecules that we have not explored. And in fact, in the popular trials, they evaluated all the other markers. They basically found that the PD-1 expression and the interferon gamma expression could be correlated with the immune response. But these are all exploratory data at this time. I think that are being studied in the future for further validations. So I think in conclusion, I think in my mind, I think the PD-L1 immunohistochemistry is currently still, for lung cancer at least, is the best available marker for selection of immune checkpoint inhibitor therapies in non-small cell lung cancer patients. And PD-L1 testing is complex, and testing and diagnostic algorithm will continue to evolve over time. When the new drugs, they use the different cutoffs, how do we implement that at the clinical level, et cetera. Those are some of the questions that are being asked. In the non-small cell lung cancer patient, I think the tumor heterogeneity in PD-L1 expression may be a significant confounding factor in its predictiveness of anti-PD-1, PD-L1 efficacy, and additional potential biomarkers for this class of drug will require validation in clinical trials. Thank you very much.
So thanks for a great talk, Ming. I think we have time for maybe 1 or 2 burning questions. Maybe I'll ask Ming a question. From a clinical point of view, if I wanted to order a PD-L1 assay on a lung cancer patient, can I do it for a lung cancer patient?
For lung cancer, yes. This is because Pembrolizumab basically require the PD-L1 status. It's more than 50% when they have to access the drug at this time. But for the other tumor types, no, there is no rationale or justification for doing PD-L1 testing. But in lung cancer now, Merck actually is pushing hard, trying to get PD-L1 testing routinely across Canada for lung cancer.
And the other question, we see a lot of lung cancer patients who have cytology-only diagnosis. Yeah. Do you think that, the impact of PD-1 and PD-L1 targeted therapies is really going to change our approach to lung cancer diagnosis?
So this is a big problem. The big problems are that all the trials that are involved, the excluded patient who only have cytology specimen, basically in lung cancer, 50% of the patients are diagnosed by cytology. That means fine needle aspiration biopsy. Those are not tissue. They are biopsying from the tumor, but they're by aspiration. And so we can do cytology specimen, but I don't know how to report it. I don't know what is the meaning of the results of the cytology specimen PD-L1 status. Right? So that's why I think right now we are excluding a lot of patients. In fact, we're excluding testing on the cytology specimen and potentially excluding a lot of patients for the therapy at this time. If the patient want to have possibility to be considered, they will have to go rebiopsy, basically. But this is an issue that need to be resolved. One of the study we need to do is to compare where there is a pair cytology and biopsy, and then see how comparable are they. Ideally, it would be a study that would actually also include response. Okay? But data is not available at this time.
Lily,
Ming, so I want to put you on the spot. So I predict, obviously, that PD-L1 will have to make it to our pathology report in the next year or so. What would be in the report? Which antibody cutoff? How do we expect to see this?
So I think in the report you will. First of all, if you ask me to do, so can I have a PD-L1 test? I say, which drug are you going to use? That's what the first thing I'll ask.
We don't know yet.
Yeah. But so right now, as I say, that the only assay that is being used, in fact, is the 22C3, which is a Pembro, because the drug is available out there. So we will specify this is for Pembrolizumab. Okay. So just to be a bit more prescriptive, because people think that they could be comparable. If you take the 22C3 for Pembro, or you can apply it to the Durva or Nivo, but there's no evidence for that at this time. So yeah, so we have to be very careful about how to do it. Yeah.
Great. Thanks so much, Ming, for a great discussion.